Today's topic of discussion is bacterial infections of the oral cavity. So here we are going to mainly deal with the bacterial infections. So in this chapter we will mainly discuss whatever topics are important, that is whichever bacterial infections are important according to the RGUHS, Rajiv Gandhi University. We are only going to discuss those infections. Now starting with tuberculosis. Our first bacteria is tuberculosis. So tuberculosis is a specific infectious granulomatous disease. Okay, so it is a granulomatous disease that is caused by our bacteria, which is your Mycobacterium tuberculosis. So TB causing bacteria is Mycobacterium tuberculosis, right? Now the morphology of Mycobacterium tuberculosis. Mycobacterium tuberculosis is a facultative intracellular parasite. Okay, so it is a parasite. But what type of parasite? Facultative intracellular parasite. It is a rod-shaped thin bacteria which is non-spore forming, as in they do not have any spores. Non-spore forming is they do not have any spores. Okay, and they are aerobic bacteria and acid fast bacilli. That is, their acid fastness is due to a high content of mycolic acid. Right, we read, if you remember in second year microbiology, we read that the bacteria which are acid fast have a higher content of mycolic acid. Now long chain cross-linked fatty acids and other soluble lipids also it has. And etiology is its human strand is responsible for many cases spread from infected sputum. Okay, so the human strand, how is the etiology of the human strand? That is from the infected sputum. Okay, and there is another strand called the bovine strand, which may be from the unpasteurized cow's milk. When the unpasteurized cow's milk is ingested, the bovine strand of TB can be transferred. Right, now TB also occurs in immunocompromised patients. What is an immunocompromised condition? Where the patients do not have much immunity. At that time, the bacteria become opportunistic and cause infections. Now coming to the pathogenesis of TB. What is the pathogenesis of TB? Firstly, there is a droplet nuclei. So droplet nuclei released by coughing. This is coughing. Okay, and there is a droplet nuclei which is releasing by coughing and sneezing. It and shouting. Different kind of modes of release of the nuclei is your coughing, sneezing, shouting, singing, and these and all are coming from which type of patient? Infectious patient, right? Okay, now the majority of the bacilli are trapped and exhaled by our ciliary action. So our nose has hairs where there are ciliary action is occurring. There the almost your 90% of the bacilli which is trapped is exhaled. Now only 10% enters the alveoli. So basically from your nose 90% is exhaled outward, and then 10% enters your mouth. Okay, only 10% enters your mouth or your oropharynx, and then it goes down to your alveoli. Right, now the mycobacterial surface binds receptors present on macrophages. Okay, so it goes and binds to the receptors on the macrophages. Okay, which leads to internalization of bacilli, Bacteria arrest phagolysosome fusion and replicate inside the macrophage. So basically these bacteria go and attach at the receptor of the macrophage. Okay, and then they stop phagolysosome fusion, and then they replicate in the macrophage. Right, now after this the macrophage eventually ruptures. When the macrophage eventually ruptures, all the your bacilli come out of the macrophages. Right, now the bacillary contents and other infected cells Now the bacillary content infects the other uninfected cells. Then there is local inflammation, and inflammatory response is generated, which is recruitment of monocytes and disease. So monocytes are recruited once there is an inflammation triggered. After that, the infected macrophages and dendritic cells spread to the lymph nodes. Okay, so these macrophages which are infected, they spread to your regional lymph nodes, right? And then they in the lymph nodes, the T cells activate and initiate something called as cell mediated immunity. So we read two type of immunity, right? In that we read about cell mediated immunity. That is happening when these infected macrophages spread to the lymph nodes, and then the lymph nodal cells activate, causing the cell mediated immunity. Now migration of activated T cells, and now after this after this cell mediated immunity is active, these T cells mediate and activate the formation of a granuloma. Okay, so basically what is happening is there is an infection. There is an infection occurring. This infection is eventually spreading out, causing inflammation. The inflammation has a response. So basically the body responds to the inflammation by recruitment of monocytes. These monocytes then these monocytes have a recruitment. Then the infected macrophages spread to the regional lymph nodes, and then there is a cell mediated immunity which is generated. This cell mediated immunity is migrated, and then there is a formation of granuloma. Okay, so this granuloma is also of two types. Okay, first is the liquefaction of granuloma causing the neutrophilic influx, which is called the primary TB. So this granuloma undergoes something called as liquefaction. Okay, something called as liquefaction. And containment of the M. tuberculosis. So first, either they go and cause the liquefaction of the granulomas, which further spreads, or these contaminated cells go in a dormant stage, that is the dormant bacilli or the latent TB, which then leads to your secondary TB. Now miliary TB results due to hematogenous spread. Okay, now we will see what miliary TB is, how it is occurring, and how it is having a hematogenous spread. Okay, now coming to your clinical features that is occurring in your TB. First clinical feature is gender. Usually males are slightly more affected than females. And then coming to the types, there are two types, intrapulmonary and extrapulmonary. So pulmonary has three types: primary, secondary, and miliary. Miliary is basically a tertiary type. Okay, and extrapulmonary is other than lungs. So one is affecting in the lungs, and the other one is other than lungs. Okay, coming to the pulmonary is occurring in three stages, as we read: primary, secondary, and miliary. Primary is the initial exogenous infection with tubercle bacilli. So this is obviously primary, so it is an initial infection. Then secondary is the exogenous reinfection of the endogenous reactivated latent primary lesion. Okay, so basically primary lesion or primary pulmonary tuberculosis is the initial infection. Secondary tuberculosis is when the primary TB is going in an arrest phase, or your latent phase, or your dormant phase, and then again reinfecting or reactivating is your secondary phase. Then coming to your miliary phase. Miliary phase is the dissemination of tubercle bacilli via bloodstream. Okay, so this bacilli which is getting infection causing bacilli is spreading via the bloodstream is your miliary TB. Okay, now coming to the extrapulmonary, that is TB occurring elsewhere other than lungs, that is your lymph nodes, pleura, genitourinary tract, bones, joints, meninges, skin, peritoneum. So other than your pulmonary, it also occurs extrapulmonarily, that is your pleura, lymph nodes, genitourinary tract, skin, etc. Coming to the three types and their clinical features in pulmonary. First is the primary. Primary is usually occurring in children. It may also occur in adults. We cannot certainly say that yes, this occurs in children. It can occur in adults. It is symptomatic and mostly few cases cause febrile illness, cough, which is usually dry or productive. Now this is also controversial that the cough is dry. It could be dry, it could be productive as well. Now coming to the secondary TB. Secondary TB is exclusively occurring in adults and the symptoms are same, your fever, cough, chest pain and hemoptysis. Coming to the miliary TB. Miliary TB is usually occurring in children and older adults who are immunocompromised, usually occurring in adults and children who are immunocompromised. Symptoms are acute febrile illness in children, and in adults gradual development of illness with anorexia, that is loss of hunger, loss of weight, fever, bilateral crackle, and lymphadenopathy, hepatomegaly may be also present. Obviously, if this miliary is the most dangerous form, which is occurring in the immunocompromised patients, in children it is just causing, just I couldn't say, it's like it is causing acute febrile illness, and in adults it is causing, first it will cause your illness, acute illness, followed by anorexia, loss of weight and bilateral crackles. Okay, then lymphadenopathy and hepatomegaly. Coming to the symptoms of general symptoms of TB. General symptoms of TB include easy fatigability, malleosis, that is your pain, muscle pain is malleus, fatigability, and easy early feature of episodic fever, chills, night sweats, loss of appetite, gradual weight loss. So first is fever, second is your chills, third is your loss of appetite, fourth is your loss of your gradual weight loss, loss of appetite, and night sweats, cough with or without hemoptysis. Now coming to what is scrofula. Scrofula is tuberculosis infection of submandibular and cervical lymph nodes. So scrofula for us is very important because this is the submandibular lymph node infection. Okay, submandibular lymph node infection, which is also occurring in the cervical lymph nodes. It may progress to abscess and remain as a typical granulomatous lesion. Now coming to the either cases, swelling of nodes is clinically present. Now the tender, painful, often slow inflammation of overlying skin is when an actual abscess could occur. So if it is, the nodes become tender, painful, which show inflammation on the overlying skin, may typically discharge pus. Okay, now coming to something called lupus vulgaris. It is your primary TB of skin. Okay, so lupus vulgaris is the TB occurring in the skin, occurs in children or adults, appearance as a papule nodule which frequently ulcerates, common on face, may occur elsewhere as well. Now coming to the oral manifestation, lesion of the oral mucosa, seldom primary rather than secondary to pulmonary disease. So it is a lesion of the oral mucosa, seldom it is primary rather than secondary. The mechanism of inoculation of this TB. Now this was about your lupus vulgaris. It is a TB of tongue. It is a TB of skin. It occurs in children and adult, which it causes papular nodules and which is frequently ulcerated. It occurs on face and may occur anywhere else. lesion of the oral mucosa is seldom primary rather than secondary. Now, mechanism of inoculation. Organisms are carried in sputum and enter the mucosa through small break on the surface. Now, from the sputum to the mucosa, if there is a ulcer or there is a break in the continuity, if there is a break in the continuity of the mucous membrane, from there the bacteria present in the sputum may enter the mucosa. Organism may be carried out through oral tissue or by hematogenous route to be deposited in the submucosa, subsequently to proliferate and ulcerate the overlying mucosa. Now, coming to the primary tuberculosis, usually involves the gingiva present as a diffuse hyperemic nodular proliferation of gingival tissue associated with regional lymphadenopathy. Okay, so we spoke about your lupus vulgaris, its oral manifestations, and how it spreads in the skin. Okay, so now we're talking about primary tuberculosis in gingiva. It also involves gingiva sometimes, and it is produced as a diffuse hyperemic nodular proliferation with little bit of regional lymphadenopathy. Now, secondary tuberculosis most commonly affects the tongue, followed by the palate and lips. So, tongue, palate, and lips are the most affected in secondary tuberculosis. Buccal mucosa and gingiva is also affected. It presents as an irregular, superficial, deep, painful ulcer. Okay, so it is producing as a painful ulcer, and it is mainly occurring on the tongue. Okay, followed by the palate, lips, buccal mucosa, and gingiva. Okay, it is present as a superficial or deep painful ulcers, and in few cases it might be painless as well. Now, the ulcer which is happening is tending to increase in size, deep seated with overhanging edges. Now, here we're describing the ulcer of a TB. So the ulcer is usually painful, and it is ulcer which is increasing in size, deep seated with overhanging edges and a plain floor. Now, tuberculosis of maxilla or mandible may be periapical tuberculous granuloma or tuberculoma. Tuberculous osteomyelitis is unfavorable of prognosis. Now, coming to the histological features, it is characterized by histological appearance is due to the cell-mediated hypersensitivity reaction. So, mainly the histology is, you can see that there is a generation of cell-mediated hypersensitivity reaction and formation of a tubercle, which is your granuloma, in which centralized caseous necrosis, foci of caseous necrosis is seen, surrounded by epithelioid cells and lymphocytes. Okay, and multinucleated Langerhans giant cells as well. Okay, then followed by your demonstration of organism with the help of Zn stain, acid-fast stain can also be seen, surrounded by epithelioid cells and lymphocytes, multinucleated Langerhans cells. Okay, so I have a histological picture here. You can refer this picture, that there is centralized caseous necrosis followed by your Langerhans giant cells, or Langerhans giant cells, central caseous necrosis and epithelioid cells, which is seen, and it is a formation of granuloma called tubercle, foci of caseous necrosis. Demonstration of organism is seen because of the Zn staining or acid-fast staining. Now, coming to another crucial part which is asked in the university a lot of times is your diagnosis. Okay, diagnosis is the presence of acid-fast bacilli in gold standard. So, how do we diagnose this bacteria? Is the presence of acid fastness in the bacteria, which is gives our gold standard for diagnosis. Okay, so the acid fastness of the bacteria is the detection of the bacteria, which is helping us to detect the bacteria. First we take is the sputum sample or a sputum smear. Image techniques or radiograph of the affected part. Mantoux tuberculin test is one more important diagnostic test. Mantoux tuberculin test. And oral lesions require biopsy. If it is break in the mucosa, then it also requires your biopsy. CT scan can also be done to diagnose the mediastinal hilary lymphadenopathy or intestinal intralesional calcifications, and high resolution CTs can also be done to identify the forms of TB. MRI can also be done for extrapulmonary TB. Respiratory specimens to demonstrate mycobacterium are sputum spot samples collected, okay, and laryngeal swabs, bronchoalveolar lavage, trans tracheal aspirations can all tests are these all diagnostic tests which are used, or samples which are used. Now firstly, microscopic smears is stained using Zn stain. There is something called Kin-Young's cold staining and rhodamine stain. Okay, so you do not need to remember, mainly remember that it is diagnosed by acid fastness and it is seen by Zn staining. Okay, you can also remember the test, that is your swab test, which is done, and for oral lesions what we do is also important. Okay, now microbial culture, we can once we collect the sample, we stain the bacteria. Before that we do culture. Okay, we culture it in LJ medium, that is your lowest stringency medium. Low stringency medium is used to conventionally culture the bacteria, and rapid after culturing we take the slide of the bacteria. Then we have your tuberculin test, which is antigen. So basically in tuberculin test, 5 units of tuberculin is putrefied, and protein deactivation of the Siberian stabilization with 1 tuberculin unit of PDRT23 is used. Dosage is 0.1 ml containing STU, and procedure is inject subcutaneously into the flux surface of forearm. Okay, now reading is taken. Basically we take a tuberculin shot, okay, and that is 0.1 ml, which is the reading is recorded after 42 to 72 seconds, 42 to 72 hours. And then interpretation of this test could be positive. Test does not confirm it is surely TB. We have to do other tests as well, and there could be false positive and false negative as well. Now the main treatment criteria of your TB is DOTS, that is directly observed therapy short course. Directly observed therapy short course, which is internationally accepted treatment, where we give isoniazid, rifampicin and prasinamide, followed by rifampicin for 4 months. Okay, isoniazid and rifampicin for 4 months. Streptomycin and ethambutol is also given at times. So majorly just remember isoniazid, rifampicin and prasinamide are the major tablets which is given in a course duration under the name DOTS, that is directly observed therapy short course. Okay, so here we conclude TB. You can just take a screenshot of the histological diagram if you want. Other than that, that's all about TB. If you have any questions, please comment below. Thank you. Our next topic of discussion would be mostly actinomycosis. Yes, so thank you for watching. Hit the subscribe button and follow for more. Bye.